as you will see today, we're going to back all of our information up by scientific studies or references to make you feel comfortable on what we're talking about. It is estimated that approximately over 2 billion people globally have micronutrient deficiencies. And those micronutrient deficiencies are associated with various laboratory results. And these are some of these laboratory results that we'll talk about today. And it's also estimated that approximately 28% of our adolescents are pre-diabetic. And that's a large percentage if you think about it. And it's increased by quite a number. In the 1999 to 2002 study or collection of data, they found that only about 12% of the adolescents were pre-diabetic. And so we've over doubled that particular number. And some people say that it may continue to go at a very high rate, and we're going to talk about diabetes today. So my question to you is, if you're a clinician, have you done your self-testing, which you've looked at these particular levels? Have you, recently done a CRP on you? Do you know your lipoprotein A level? Do you know your homocysteine level? And of course, do you know your vitamin D level? Now, there's a lot of other tests that we can look at, but these are some that are very important. And I'm going to correlate these particular tests today with various pathologies, and you'll see why by the end of the webinar, it's important to know these particular numbers. So, as I mentioned, that diabetes is an up-and-coming pathology that continues to increase, not just in our adulthood, more or less, population, but also in our childhood and / adolescence. And you can see here that 1 in 3 Americans will have diabetes by 2050. Now, once again, those particular individuals will be on certain medications or be told to be on certain medications. And we'll talk about that today on how those medications may affect our micronutrient status. One of the major players in diabetes, or the relationship of diabetes, is vitamin D. And most of the time when people talk about diabetes, they will talk about dietary habits, of course. Do I go on a ketogenic diet? Do I go on the gluten-free diet? Do I go on the Mediterranean diet? What diet do I go on? But they don't emphasize enough about the micronutrients. And these are some of the actions of vitamin D. And this is how you can help a person that has glucose issues, or even if they have type 1 diabetes, how can we benefit them with vitamin D? So everyone out there that is pre-diabetic or diabetic, whether it's type 1 or type 2, should definitely be looked at in regards to vitamin D status. And you can see here that not only is vitamin D important for the synthesis and secretion of insulin, but also increases the insulin receptors. And this has been known for numerous years, and this keeps coming up on a regular basis. We're going to talk about some lifestyle changes that actually may affect your vitamin D status too, and also some medication that affects this particular one. When we talk about vitamin D, we often talk about or include magnesium as well. Magnesium has definitely been shown to have an impact on our glucose regulation. And you can see there's several different functions of magnesium or relationships of magnesium. And I'm going to show you how your lifestyle actually can affect this particular status. And I'll also show you what previous testing on the validity of that testing, and should we still be doing some testing that several of us have learned in our past education. So once again, this is something that is very, very prominent. And magnesium has numerous functions, as you know, in the body. So what's the relationship of vitamin D and magnesium? So one of the things is, of course, vitamin D increases the absorption of magnesium. And then this also increases the transport of magnesium from the extra to intracellular space. Magnesium is required for the hydroxylation of vitamin D. So once we take vitamin D in, as you know, it goes to the liver. And then once again, it gets converted there from hydroxylation and then goes to the kidney and goes through its final hydroxylation. Those hydroxylation functions cannot occur without magnesium. So if you're just checking someone's vitamin D status and their vitamin D status on their serum may be normal, it doesn't necessarily mean that it's going through the hydroxylation process or it's being utilized at its full capacity. Because once again, these two nutrients are highly connected to one another. Well, what's interesting is some of the medications that people take today are affecting both of these. And so if a person is affecting magnesium, say an individual is on a antihypertensive drug like hydrochlorothiazide, hydrochlorothiazide actually enhances the loss of magnesium. So if we are losing magnesium, then it's also affecting our vitamin D status. And so when we read the literature, we have to be very careful about the literature in regards to research, because if the people that are doing the research and they're just isolating magnesium information or vitamin D information, and they're not correlating the two or monitoring the other nutrient that's so synergistic with this particular group, then once again, we have to question whether or not that research is really fully validated. And that's something that I think is very interesting to watch, because often I'll see vitamin D research that doesn't come out like people think it will as far as the results, and yet they haven't monitored the magnesium in that research, or vice versa. They look at magnesium and they haven't monitored the vitamin D. So when you're reading the literature, it's very important that you see what these individuals are doing and how they're monitoring, or are they correlating this. And that's the difficult thing about nutrition research, is so many of these nutrients, as you will see today, are interconnected. And so by looking at one particular mineral or vitamin or metabolite, you may not be getting the correct result that you're looking for, or the best result, if you don't consider the other ones. So these are some of the food choices, once again, for magnesium. Of course, you can see some various dietary supplement forms. There's more forms than that are listed here, once again, but these are just some examples. And this was published recently in Nutrient Journal in 2021. And then you can see some factors that increase the bioavailability of this particular mineral, and then some that decrease the bioavailability. So how do we know really if we have the adequate amount of magnesium or some other nutrient in our body if we don't measure it objectively? We can't just assume, oh, we eat a diet high in magnesium, we must have adequate magnesium, because you can see there's several factors that enhance or decrease the bioavailability. And to what extent? And this extent can be different for everybody out there. So we all are individual and subjects that have various biochemistries, and these various biochemistries play a role. We also have to look at genetics. How are genetics affecting this? How are the receptors, say the vitamin D receptor, affecting the vitamin D uptake, and how is that being affected by magnesium, or is it being affected by magnesium, and so on. So once again, I think it's very important to realize that we can't just assume that people have adequate statuses of a vitamin, mineral, amino acid, or whatever, just because their intake or just because their diet, it looks adequate. And I'll talk more about that, especially when we get into some different lifestyles and show you how some of these lifestyles really compromise our nutrient status. So you can see here by the second bullet that back in 1980, there was a study done showing that serum magnesium is generally considered an unreliable indicator. And yet it's amazing to me on how many times I see patients come into my office and they have issues with migraine headaches or muscle cramps or muscle spasms or cardiovascular disease. And of course, they have had the physicians that have done some laboratory diagnostics have looked at their serum magnesium, their serum calcium, their serum vitamin D, and so on, and consider that to be adequate evaluation. And it's not. But once again, a lot of physicians continue to use what they've been trained instead of keeping up with the literature. And you can see here in a journal in cardiology in March of 2011, they actually looked at intralymphocytic magnesium, and they found it to be very correlative with essential hypertension. And there's a lot of research that's been done on magnesium deficiency and cardiovascular disease, whether it's cholesterol issues, triglyceride issues, hypertension, atrial fibrillation, and so on. But once again, if we're looking at the serum magnesium as whether or not we should supplement or increase someone's dietary intake of magnesium, we're looking at the wrong indicator. And once again, we're not going to solve the problem. So we're going to go and give something else to an individual that may be deficient in something else based on another type of laboratory testing, and once again, find the correct answer. Chromium is probably one of the most common nutrients talked about with diabetes, whether it's type 1 diabetes, type 2 diabetes. And of course, a lot of people use this product or have seen this product in various products to help promote weight loss. And you can see here various mechanisms that chromium is involved with. One of the major things that chromium does for the diabetic is, of course, sensitizes the insulin receptors. And by doing that, of course, it's going to be beneficial for both diabetics, your type 1 diabetic and your type 2 diabetic. It doesn't have any particular function in regard, as we know right now, to increase the production of insulin, but more of the insulin receptors. And there are numerous studies to show that chromium has been available to help lower HbA1c. Now, the question is in these studies that it didn't show that, you have to look at dosage, you have to look at the form, because there's different forms of chromium that are going to be higher or lower in bioavailability, and that's something very, very important. And you also have to look at other products that complement this particular mineral. Is magnesium deficient in those individuals that they're studying? Is vitamin D deficient? Is it adequate? Is niacin, some other products that I'm going to talk about. The other thing you have to look at is timing. I've seen some studies where they've done chromium studies, and they say after 1 month of chromium supplementation, we did not see any change in serum glucose levels. Well, you can see here that it can take several weeks sometimes to really see the change, or even months. And so once again, when we evaluate these research articles, we have to be very careful on looking at the conclusion. Did they do their job properly to look at these nutrients as a whole or individually? We're seeing that today in medicine, where several medications are given together to complement one another. And as a result, once again, we've seen some great benefits with medication when they've been given in combination. So the point is, the same thing is true with our nutrients. What about zinc? Zinc is very interesting. One of the things we often hear with diabetics is diabetics don't heal well compared to non-diabetics. Well, one of the major players in healing, of course, is zinc. Zinc makes collagen, zinc makes elastin, zinc enhances the white blood cells in regards to function, the phagocytic capabilities, it helps with antibody production and so on. And one of the other things we find that diabetics, when their glucose is out of control, that they actually increase the zinc in their urine. And we also have seen in studies where the absorption of zinc is decreased in your diabetic patient. So now maybe a 30 milligram dose of zinc is good for a non-diabetic to correct their zinc deficiency, but it may take 40 or 50 or 60 milligrams of zinc to correct a diabetic. The question is, what are you doing to see if that's the case? What are you monitoring? Are you just assuming, or are you just doubling the dosage and think, well, that should cover it? Or do you have some objective data, once again, that's going to provide you with enough evidence to feel comfortable that you are correcting the individual? And the other thing is that these individuals, the zinc and the chromium can be very synergistic at times, but in large dosages, they can actually be competitive at times. And so we see that from time to time. And I'll talk about some other nutrient interactions down the road here. Niacin in the form of amide form, not the nicotinic acid form, not the form that makes you flush. When people talk about non-flush niacin, we have to be careful about what they're talking about. Are they talking about this form, or are they talking about inositol hexaniacinate? Because inositol hexaniacinate is also considered a non-flush form of niacin, but it's not the same as this form. This is the form that is the biological active form. This is the form that we see for all of us that go back to our biochemistry or chemistry days, and we remember seeing NAD and NADP and those particular products. This is the form that we're talking about, either niacinamide or nicotinamide. Okay, so it's the amide form. As you can see here, one of the things, it's a component of the glucose tolerance factor. Another factor is that it's been shown to possibly decrease kidney involvement with the diabetic. As you know, kidney involvement is very high on the list as far as one of the morbidities associated with diabetes. And when we look at that, we have to consider the prevalence of that. And there's some research that have actually noted that when people are diabetic, if they have diabetes for 10 to 15 years or longer, that they might have as high as 30 to 50% chance of going on dialysis if it's not controlled. And so once again, that's very, very important. And you can see here, once again, the dosages that has been in the literature that we see in the clinical studies that actually are acceptable for niacin. So one of the most common drugs for the diabetic, of course, the type 2 diabetic, is metformin, or a combination of products that contain metformin. And metformin, as you know, and the literature is very strong in this aspect, has shown to cause a B12 and or a folate deficiency. And this will become very important down the road here this afternoon as I correlate the B12 and the folate with one of the markers that we talked about at the very beginning of this webinar. Another common group of drugs that are promoted out there are proton pump inhibitors. And you can see there's numerous nutrients that are affected. I didn't list all of them. I listed some of the more common ones that are affected with the proton pump inhibitors. And then, of course, statins. Statins are commonly associated with the diabetic. Because if you're diabetic and you don't control your diabetes, you very often have cholesterol issues. And we know that coronary artery disease is highly associated with diabetes. And so a lot of diabetics are put on statins prophylactically, or if their cholesterol starts to get elevated or their glucose gets out of control at a very high rate, that we see the cholesterol get worse. As a result, these statins actually can affect several nutrients. The most common one that everybody talks about, of course, is coenzyme Q10. But you can see vitamin D is affected, selenium is affected, carnitine is affected, vitamin K is affected. And these are very, very important nutrients because these nutrients affect cholesterol levels, they affect the integrity of the vasculature as far as preventing the hardening of the arteries or the vessels. It affects our immune system, it affects our ability to metabolize fats, it affects our muscle integrity, our muscle function. And so several things come out of this particular medication. And so we often hear people say, I'm tired all the time since I've been on the statin. I have muscle pain since I've been on the statin. Or my joints hurt. Or my blood pressure has gone up. Now, even though there's some benefits of this particular group, which I'll talk about in a little bit, we also have to realize that there's some serious nutritional deficiencies, micronutrient deficiencies that occur with the statins along with those other medications. And it's not unusual, believe me, and you've probably all seen this, to see a combination of these deficiencies from several medications that these individuals are taking. But once again, if we look at the serum levels of magnesium or the serum levels of vitamin D, it may not be really telling us the situation because those particular markers only look back maybe 48 to 72 hours. And as a result, we are only getting what's going in the serum or the plasma when we are evaluating those particular markers. So here's a list of some of the more common nutrients that are deficient in the diabetic, whether it's type 1 or type 2. And these particular nutrients have been shown to help in several aspects. Once again, have been shown to complement the diabetic with blood pressure, complement the diabetic with neuropathies, complement the diabetic in preserving their kidney function, and so on. So once again, you don't want to just start throwing these particular nutrients at the patient, because once again, you don't know which one is really needed, or are some of these going to be interacting with one another, or the dosage. You have to know what the dosage is, and there's certain dosages we look at as far as ranges, but the point is that we want to make sure that we're attacking the right nutrient for the deficiency that that diabetic has. It's a common saying that I have in my lectures when I talk to clinicians is, if your car needs gas, don't give it oil. And more or less what I'm saying is, of course, if the diabetic that you're dealing with is magnesium deficient, but they have adequate vitamin D, don't give them more vitamin D, because it's not necessarily going to help their magnesium. We need to correct the nutrient that's missing. One of the things that we are seeing today is, of course, in the past several years, and I've been doing this for over 40 years, is we've seen the cholesterol levels change. I remember several years ago when the total cholesterol accepting was under 260, then it went to 240, then 220. Then, of course, over probably decade and a half or so, it's gone to, we wanted a total cholesterol less than 200. And so in order to achieve that, one of the things that's happened in society is the statin medications, as far as prescriptions, have gone up in number. And as a result, a large part of the population is prescribed this particular group of medication. And you can see there's numerous benefits of statins. They have an anti-inflammatory effect. There's some immunomodulatory effect. They work as an antioxidant. They have some antithrombotic particular effects. And there is some other indications that they may help some other pathologies. But the point is, even though there are some benefits here, there is also some detriment associated with this particular group of medications. Now, there's numerous statins out there, and you can see, for the most part, the half-life of most statins is about 1 to 3 hours. Atorvastatin and rosuvastatin, of course, have half-lives that are about 15 to 30, and on the average, 19 hours, respectively. So they last longer, of course, and depending on if you're prescribing it or someone else has prescribed it, the timing. Some people are told to take it in the morning. Some people are told to take it in the evening because of possible elevation of cholesterol more in the evening than in the morning, and vice versa. But whatever the case is, a statin taken in a 24-hour period has the tendency to affect certain nutrients. And as I mentioned, probably the most common nutrient talked about today, and you see this on several advertisements on TV all the time, is if you are taking a statin, you probably should be taking CoQ10. And this is a schematic here showing you that the HMG-CoA reductase inhibitors, that's the statin, and how it interferes in this pathway of cholesterol production. And in that pathway, kind of a sidebar, CoQ10 is synthesized. And if we're blocking this pathway above, and yes, we're definitely going to lower cholesterol, we also have the high tendency to affect CoQ10. And this is one of the reasons why people that take this particular drug develop muscle pain, because one of the side effects of, or one of the findings of CoQ10 deficiency is muscle pain. Another one is fatigue. Another one is memory loss. Another one is neuropathy. So people taking a statin and say they're diabetic and they're taking a statin, now they have metformin that could be depleting B12 and folate, which could cause neuropathy. They can be taking a statin that's affecting their CoQ10, And so they have 3 nutrients that actually could cause neuropathy if they're low in number. And yet, what I often hear from my patients, if they're diabetic, is, oh yeah, I have neuropathy. My doctor told me I have neuropathy, and that's because of my abnormal glucose regulation. And it may be that, but yet the person's on metformin, the person's on a statin, and it's never been mentioned to those patients that, oh, by the way, the statin that you're on, it may be depleting certain nutrients that may be causing your neuropathy. Or that metformin that I have you on may be depleting a couple B vitamins that's causing your neuropathy. And I think that's very interesting because it's so vast in the literature, is why these clinicians are not providing that information, or why they should be supplementing these individuals or testing for these individuals to see if that's going on. Now, this is very important. And you can see here, there's literature that goes way back. I just pulled some older literature. And the reason I did that is I wanted to show you how long this has been actually going on. In fact, there's some articles back in the 1980s that confirm CoQ10 deficiency causes neuropathy. And you can see here in these studies with different dosages and timing of statins on what it's done to CoQ10 level. Now, what's interesting about CoQ10 is found in every cell in the body, and especially importance with cardiovascular. CoQ10 deficiency has shown to affect cardiac ejection fraction. Another area where CoQ10 is getting a lot of press today is CoQ10 deficiency in Parkinson's disease and CoQ10 in Alzheimer's. I just had a patient in today that's been on a statin for 20 plus years. His major reason he's seeing me is memory loss. His wife is very concerned about it. She's on a statin, she's on a lower dose statin, but she also mentioned that she's starting to lose her memory. And I can tell you that after testing him, he had a significant low level of CoQ10 in his body. So it confirmed what the literature says, that CoQ10 deficiency is associated with memory loss. CoQ10 deficiency is associated with statin usage. And yet he was never told by his clinician, his general practitioner or his cardiologist, to go on CoQ10. And once again, it's been on a statin for a very long period of time. And you can see how long this information's been out there. My mother actually developed rhabdomyolysis from Lipoprotein, and she's in a wheelchair to this day. And we did muscle biopsy, and we have evidence from the muscle biopsy that she has statin-induced rhabdomyolysis. And the sad thing is, I didn't know that she was on it at the time, but she told her cardiologist after 3 months of being on it, her muscles started to hurt. And he said to her, oh no, that's very rare. That doesn't happen. You must be doing something at home that's actually causing your muscle pain. Well, she continued to go along with her cardiologist, and a few years later, they moved to Houston, and she came to my office and we did some testing. And of course, her CK level was 8 times normal. And once again, we did further testing. Like I said, we did muscle biopsy on her, and we have evidence of permanent muscle damage as a result of statin usage. So once again, it's not as rare as people think. You probably all see it or hear people complain about it, but it's very interesting. Now, one of the things that, of course, we do with patients, if they have cardiovascular disease, we tell them to go exercise. Say, well, you know, if you exercise, you can lower your cholesterol levels, you can lower your triglyceride levels, and you can probably even lose weight that's going to help your blood pressure. So isn't that great? Well, one of the things we have found over the years, and I see this all the time, and I have a lot of case studies on this, is these individuals start to become deficient in CoQ10. So if they have elevated cholesterol and they're put on a statin, and now they're told to go exercise, they may actually deplete their CoQ10 more and get themselves into further compromised position. And once again, this is something that has to be considered with these individuals, is other ways of losing a nutrient status by yet trying to promote a good thing like exercise. So people, and we see this all the time. I know you have patients like this because I have patients like this. I have marathoners, triathletes, CrossFit patients that have elevated cholesterol. You say, well, wait a minute. If they're exercising that regularly, why do they have elevated cholesterol? Because there's other things going on biochemically that are causing that. Vitamin D, same thing as I mentioned. Vitamin D deficiency not only helping diabetes, but also associated with coronary artery disease. And you can see this, that they have correlated vitamin D with the severity of coronary artery disease. We also, of course, see low vitamin D status causing insulin resistance, affecting our HDL. I had a patient a couple of weeks ago coming into my office. He's exercised all his life, and he's never been able to get his HDL cholesterol up. It's always been low or low normal. And for the exercise amount, you would think it would be at a very high level. Well, when he first came to me, we tested him, and of course, he was vitamin D deficient. And when I showed him that, I said, this is one of the reasons why you can't get your HDL up. So by pushing someone harder into exercise or more frequent exercise isn't necessarily going to correct it, because you're not correcting the problem. You're not getting to the root of the problem. Now, we've also seen, as I mentioned, that vitamin D deficiency is associated with statins, and especially if the person has some type of myopathy involved. So if we're just looking down that tunnel and saying, oh, you're on a statin, we need to give you CoQ10, and you're not considering this, then once again, it's an issue. Vitamin D, as I mentioned, has an impact with insulin, has an impact with serotonin, has impact with our bone. I mean, it has numerous functions. And so if we are affecting the vitamin D status, or if a person has a vitamin D deficiency and they take a statin, they may actually experience some of these side effects more often or severe. And so once again, this is a very important nutrient to look at. So what about carnitine? Carnitine has also been involved with muscle integrity, whether it's cardiac muscle or skeletal muscle. Carnitine is very, very important for muscle integrity. It has a huge role with mitochondrial function, and once again, has been associated with sarcopenia, when people get to 60 years of age and above, and of course, their muscle integrity goes down. So one of the things I want to emphasize is when people take CoQ10, they actually can push themselves into carnitine deficiency. And vice versa, you can take carnitine and push yourself into CoQ10 deficiency. So here's an individual that is on a stat, and we've all heard, oh, we better give this person CoQ10. And after 6 to 9 months or maybe a year, this person starts to develop muscle pain. And so without doing objective testing, the common sense approach would be, oh, either I need to cut down the statin on this patient, or I need to increase the CoQ10. Well, in actuality, you might have caused a carnitine deficiency. And if you caused a carnitine deficiency, the person has muscle pain because of that, or they have neuropathy because of that, or they even have fatigue. And so if you don't have some way of objectively evaluating the CoQ10, the vitamin D, the carnitine, you're guessing on your therapy. And none of us want to guess on our patient's therapy, and none of us want to have our health decisions made. Another thing that's very interesting about statins is, for a long time, they talked about a possibility affecting this particular marker. As you know, lipoprotein A is a cardiovascular marker by itself. It's a very small particle. And by itself, without abnormal cholesterol or triglyceride levels, this can cause atherosclerosis. This can result in hypertension. It can result in myocardial infarction. So we look at this very closely, and this should be included when we evaluate a person's lipid levels / cardiovascular risk factors. And you can see here that, and this was published recently, that lipoprotein A can be lowered with CoQ10. It can be lowered with carnitine. And this is a study where there's no statin. When they added statins, they actually saw the lipoprotein A increase. Now, I have several patients pre and post statins that I can show you where we've had elevated lipoprotein A. And lipoprotein A, like I said, is very damaging to the vasculature. And so you're actually increasing the risk, the coronary risk, by increasing LP little a. So here we're given statins to lower cholesterol, and we get a good cholesterol, total cholesterol under 200, but yet we elevate the lipoprotein A, which is something we don't want. And if you're doing the standard lipid panel, you are not going to see this on the standard lipid panel. So this is something that is very important to monitor. It's been out in the literature for years. It's getting more and more press as we go along in the healthcare systems, and yet a lot of people still don't get it tested. As I mentioned, carnitine is one of the nutrients that actually helps lower lipoprotein A. However, in addition to carnitine and CoQ10, we also want to monitor pantothenate, because pantothenate actually can get lowered with one of those or both of those particular nutrients. So let's talk about osteoporosis. I'm going to go through some of this rather quickly because a lot of it you already are aware of. And as you can see here, vitamin D is sticking right out there because that's the big thing today. Oh, if you have osteoporosis, you better take vitamin D and you better take calcium. And of course, those are the major things that we look at. But you can see here that osteoporosis or osteoporosis-related fractures are very prevalent today. You can see here that 1 in 2 women and 1 in 4 men over the age of 50 will fracture at some time in their life due to osteoporosis. And because of that, it can result in a lot of money and a lot of different problems. Their balance can be affected. They might have to have a total hip replacement, or they might, suffer with chronic vertebral pain because they have a vertebral fracture. And once again, so they might be on pain medication the rest of their life that may be also affecting their nutritional status. So these aren't all of them, but these are a large majority of the nutrients that you have to consider with osteoporosis. And the question that you have to ask yourself is, am I evaluating all of these? Am I looking at other nutrients besides calcium and vitamin D? If you're not addressing osteoporosis. And it's interesting because some of the pharmaceutical literature out there, they talk about the bisphosphonates and other medications like teriparatide, and they say they work better when they give calcium and vitamin D. Well, what about giving vitamin C with it? And what about K and zinc and these other things? They probably even work better. Maybe they might not even be needed. But the problem is, if you don't address all of these nutrients, you can have one of these nutrients that's low, and you can continue to have acceleration of osteoporosis. Magnesium is a common one. Like I said, I'm going to go through these rather quickly just because of time, but it's something that always has to be addressed. And once again, if you address magnesium, as I mentioned, you have to address vitamin D. One of the things that all of us have experienced in our life is a thing called stress. And this could be stress because of psychological pressure. This can be stress because of physical stress, like exercise. But whatever the case is, when we are under stress, we actually can affect our magnesium status. And I could give you several hour lecture on stress and how it affects us nutritionally, and definitely how it affects our bones. And so when people are under stress, we need to definitely address those nutrients that are affected by stress that also affect the bone. And once again, vitamin D, as you know, has a major part to play, but not the only one to play. Zinc is a nutrient that's often overlooked. I see this all the time in my practice where people say, my bone mineral density continues to get worse, and I'm taking calcium, I'm taking vitamin D, I might even be taking magnesium, but they're not taking this. And once again, we test them and they show this deficiency. These are some of the findings that are associated with zinc or correlated with zinc. The alkaline phosphatase, which is a common enzyme monitored for skeletal integrity. Zinc is important for collagen formation. Of course, it makes protein synthesis, different types of proteins in the body. There's a ratio that we look at, the zinc to copper ratio. If we take too much zinc, we can actually lower the copper level, and vice versa. So that has to be looked at. And you can see here that it's estimated that 1/4 of all adults consume less than the average requirement for copper. Well, if they're not consuming enough copper, they can predispose themselves to, once again, osteoporosis. They can also predispose themselves to cardiovascular disease. And once again, due to limited time, I won't cover that today, but copper is a major player in cardiovascular disease. And you can see here, once again, copper plays a role with the collagen synthesis, which of course allows the minerals to attach, other minerals to attach, and of course solidify the bone. Manganese is another nutrient that is often overlooked, but very important for osteoporosis, and once again should be addressed. Vitamin K. There's a big talk now, of course, with vitamin K2 and vitamin D, and there's a lot of literature that shows that. Once again, vitamin K2 is primarily found in your fermented products as it's listed here. But another thing that's very important with vitamin K2 is a large portion of that is produced by the normal flora. So if we have disruption of the flora, we have ability to have an adequate amount of vitamin K2. Vitamin K1 is primarily found in your cruciferous plants. And so once again, they have different functions to some degree, but they complement each other as well. So this is a very important nutrient. Once again, if you go back and look at even some of the more current studies with medications that are used for osteoporosis, very rarely do they say, oh, in addition to this medication, we gave calcium, we gave vitamin D, we gave vitamin K, we gave magnesium. No, they don't do that. And I know they're trying to limit their variables to some degree, but if you don't look at all the nutrients that maintain bone, then how can you really say that you're doing an adequate evaluation of that particular nutritional intervention? Vitamin C, once again, we cannot make collagen without vitamin C. And as you know, depending upon who you read, there's 13 to 15 different types of collagen in the body, and vitamin C is very important for that. So when we talk about homocysteine, everybody usually talks about homocysteine and cardiovascular disease relationship. But you can see homocysteine elevations have been associated with osteoporosis, pregnancy complications, Alzheimer's, migraines, and on and on and on. And I could talk once again for numerous hours on this particular subject. But one of the things that I want to really emphasize to you is homocysteine elevations definitely have been shown for numerous years to affect our bone integrity. It is one thing that I highly emphasize to my patients, especially my female patients, on an annual basis. I want to know your homocysteine number because this has an impact on your bone integrity. And we know that homocysteine is highly affected by some B vitamins. So once again, when we're evaluating osteoporosis literature, are these researchers addressing homocysteine? Are they addressing the B vitamins and saying, oh, this person was low in B12 or this person was low in B6, and that caused a homocysteine elevation and caused some problems? So these are some of the nutrients that are highly associated with homocysteine. They're not all of them, but once again, some of the major ones. And these are ones that you need to evaluate. So cysteine or glutathione or choline can affect that homocysteine level. If it does, once again, it can affect those other pathologies that I mentioned. So I want to just show you a couple of actual cases out of my office. Once again, due to limitation of time, I'm just going to show you a couple. But here's an example. Here's a 79-year-old female that came to my office with severe osteoporosis. She was taking calcium. She was taking vitamin D. And her BMDs every year. She was actually doing a BMD every year because it was so severe instead of every other year. And if you look at the bottom of this page, you see that her homocysteine level was elevated. Once we corrected this, her osteoporosis started to decrease and her BMD studies improved. And the point is that once again, we took a product away from the system as far as lowered it through B vitamin and some other nutrients involved and actually affected her bone integrity. This is a case that is strongly supported by the literature. And this is what's really important. So if you deal with osteoporosis or osteopenia on a regular basis, or have a female population that's high in your practice, you need to be doing homocysteine every single year. Now, this number, the homocysteine, can change every 3 to 4 months in regards to if you want to monitor it more rapidly or more frequently than every year, you could. But once again, definitely do it at least on an annual basis. Here's a situation, and we hear this all the time. Oh, doc, I eat real healthy. I exercise on a regular basis. And how can I be deficient in anything because I eat so healthy? Well, here's an individual that exercises 5 to 6 days a week, a 34-year-old individual. And if you look at this particular schematic, you'll see that several nutrients are borderline level. And of course, biotin is severely low. And this is showing you, of course, white area is normal, yellow is borderline, and blue in this particular graphs are considered functionally deficient. And you can see there's several black numbers and a red number that are indicating that. We look at it further, and you can see in this particular page that vitamin E is abnormal, and that's something we see with heavy exercise, is people that exercise very frequently and for a long duration often have antioxidant statuses that are subpar. And that's strongly written in the literature, and some say it's beneficial, some say that we don't really want to improve the antioxidant status because it affects our overall muscle function. And I can disagree with that because I have a lot more individuals that suffer with problems and their free radical or their antioxidant status is very poor from their exercise level. And so lastly, the point is people come into us and they say, I don't have any major problems, doc. Do I really need to be evaluated? And once again, it's just like hypertension. They call it the silent killer, okay? Well, the same thing with vitamin and mineral and metabolite deficiency. We may not know that they're low or borderline or get to the point of yet expressing a pathology, but they're definitely at a point that can start a pathology going. Osteoporosis, diabetes, coronary artery disease, Alzheimer's, and so on. Or they may be taking some medication that's causing some of these deficiencies, and they have some common findings like, muscle pain or fatigue, or they might have headaches, and they're just assuming, well, everybody has headaches from time to time. Everybody suffers with muscle pain, and they just kind of push it aside because they think, well, so many people have it, it's just normal to have it. No, it's not normal. As you all know, those are warning signs that something is abnormal with our body.